Bismillahirrahmanirrahim. Today we are going to discuss hypertensive disorders in pregnancy. Learning objectives of today's presentation. At the end of the presentation, the student should be able to understand the classification of hypertension in pregnancy, to understand the pathophysiology of preeclampsia, to identify risk factors for preeclampsia, and to describe management and prevention of preeclampsia. The remaining part of the hypertensive disorders we will discuss in the next picture. Introduction. A brief introduction to the topic. Hypertension is common in pregnancy. About 1 in 10 pregnant women experience one or more episodes of high blood pressure prior to delivery. The majority of these women have gestational hypertension, also called pregnancy induced. Mean they have normal blood pressure before pregnancy, but in pregnancy they have high blood pressure. And the gestational hypertension is not associated with the adverse outcome. However, 3% of these women will develop preeclampsia. Preeclampsia is a leading cause of maternal death. Preeclampsia is also associated with the fetal risk like fetal growth restriction. Some of the women will enter in pregnancy with high blood pressure, mean that they have chronic hypertension. And the patient with chronic hypertension have both maternal and fetal risk. Now, classification of hypertension in pregnancy. There is a wide range of classification of hypertension in pregnancy, but a simple classification. A pregnant woman with high blood pressure can be put into one of these three classes. Number one, non-proteinuric pregnancy-induced hypertension, also called gestational hypertension. Second is preeclampsia, and third is chronic hypertension. So, if a patient presents with the high blood pressure, you have to put them in one of these three classes. Number one, non-proteinuric pregnancy-induced hypertension. Non-proteinuric pregnancy-induced hypertension is hypertension arises for the first time in the second half of pregnancy and in the absence of proteinuria. Mean that a second half most probably after 20 weeks of gestation. This means that a patient who present you in pregnancy and if you review the previous record, the patient have normal blood pressure at booking visit and after 20 weeks anytime. It doesn't mean that after 20 weeks mean at 21, 22. Patient can present at 22 weeks, at 28 weeks, at 30 weeks with a high blood pressure. But when you go previously, the patient have normal blood pressure before that time. So this is called pregnancy-induced hypertension or gestational hypertension. Second is the chronic hypertension. Women who have confirmed hypertension before pregnancy or in the first half of pregnancy is most likely to have chronic hypertension. For example, if a patient comes in first trimester or at booking and you check her blood pressure and it is raised, but the patient doesn't know about it, it means that she is having chronic hypertension. Or a patient is known to have hypertension before pregnancy and she entered into pregnancy, then that is called chronic hypertension. Third is preeclampsia. Preeclampsia is defined as hypertension of at least 140 by 90 millimeter of mercury recorded on at least two separate occasions and at least 4 hours apart and the presence of at least 300 milligram protein in a 24-hour urine report collection arising de novo after the 20th weeks of pregnancy in previously normotensive women and resolving completely by the 6 weeks postpartum. There are 4 to 5 points in this definition. Cutoff is 140 by 90. Second is on two separate occasions. It means that a single reading of blood pressure 140 by 90 or more than this should not be labeled as preeclampsia because because of some attention the patient may have high blood pressure. So a single reading is not diagnostic of preeclampsia. So, so it should be checked at least on two separate occasions and these should be at least 4 hours apart. Third is the presence of proteins in urine is must for the diagnosis of preeclampsia. And the fourth is that it first time arises after 20th weeks of pregnancy. And the fifth is it should be resolved completely by the 6 weeks postpartum. So if you check a patient blood pressure after 6 weeks postpartum and it is high, that means this patient is having chronic hypertension, but it was first time diagnosed during pregnancy. Now, what are the risk factors for preeclampsia? There are a number of risk factors, and whenever we are going to take history at the booking visit, we have to keep in mind all these risk factors for preeclampsia, and if there are any, we have to highlight it. Preeclampsia is common in first pregnancy. Preeclampsia in any previous pregnancy is also a risk factor for preeclampsia in the present pregnancy. If there is 10 years or more gap between two pregnancies, then there is risk of preeclampsia. Maternal age 40 years or more, body mass index of 35 or more, family history of preeclampsia. Family history means history of preeclampsia in mother or sisters. Booking diastolic blood pressure of 80 millimeter of mercury or more, multiple pregnancy, and certain underlying medical conditions like pre-existing hypertension, pre-existing renal disease, pre-existing diabetes, and antiphospholipid antibodies. So, if these risk factors are present in a patient, we have to be vigilant for the development of preeclampsia. And these risk factors doesn't mean that if these risk factors are present, the patient must develop preeclampsia. But we have to be more vigilant. Now, what is the pathophysiology of preeclampsia? Preeclampsia only occurs in pregnancy. It means that the pathophysiology of preeclampsia is related to some event that occur only in pregnancy, but it also occurs in patient with molar pregnancy and patient with abdominal pregnancy. So the main component contributing to preeclampsia is the placental tropoplastic tissue. General thinking suggests that the development of preeclampsia is a two-stage process. In the first stage, trophoblastic invasion is patchy and the spiral arteries retain their muscular walls. This prevents development of the low resistance uteroplacental circulation and leads to uteroplacental ischemia. In the second stage, the uteroplacental ischemia results in oxidative and inflammatory stress with the involvement of secondary mediators leading to endothelial dysfunction and activation of the coagulation system. This picture shows normal physiological changes of spiral arteries by a trophoblast. This is unmodified spiral arteries. This is the endothelium, this is the smooth muscles, and this is the tunica media. This is the trophoblastic tissue. This invades the spiral arteries, and there is the loss of the muscular wall of the spiral arteries, and this is replaced by the trophoblastic tissue. This smooth muscles of endothelium is replaced with the trophoblast. So this result in the development of the low resistance, high flow of the blood in the uteroplacental tissue. So when there is the this normal development is impaired, this results in high resistance, low blood flow. The reason why this trophoblastic cell not properly invade the spiral artery is not known, but may reflect an abnormal adaptation of the maternal immune response to the fetus. In this picture show the pathophysiology in a summarized form. If a patient is having genetic predisposition to preeclampsia, there will be a normal immunological response of the mother to the fetus. This will result in deficient trophoblast invasion. Due to the deficient trophoblast invasion, there will be high resistance blood flow resulting in hypoperfused placenta. And because of ischemia, there will be release of the different circulating factors causing vascular endothelial cell activation and maternal endothelial cell dysfunction, leading to maternal syndrome and causing the clinical manifestation of the disease. Preeclampsia is a multi-system disorder causing problem in multiple systems of the mother. So the systemic involvement of in preeclampsia is first cardiovascular system. In normal pregnancy, there is peripheral vasodilation resulting in fall in total peripheral resistance and low blood pressure. The normal vascular changes you have studied previously, normal physiological changes of pregnancy. So in cardiovascular system, in normal pregnancy, there is peripheral vasodilation. And preeclampsia is characterized by a marked peripheral vasoconstriction resulting in hypertension. And due to the increased intravascular pressure and the loss of the endothelial cell integrity, there is greater vascular permeability, and this contributes to the generalized edema of the body. So in cardiovascular system, there are two main changes. One is peripheral vasoconstriction, and second is the increased vascular permeability resulting in edema. Second is renal system. In kidneys, a characteristic lesion called glomeruloendotheliosis is seen in preeclampsia, and this is relatively specific for preeclampsia. This glomeruloendotheliosis is associated with the impaired glomerular filtration in the selective loss of proteins such as albumin and transferrin, leading to proteinuria. This loss of protein leads to decrease in plasma oncotic pressure and exacerbate the development of the edema. Third is hematological system. Due to the endothelial damage, the platelets adhere to the damaged area, and the diffuse vascular damage is associated with laying down of the fibrin. So preeclampsia is associated with the increased fibrin deposition and reduction in the platelet count will occur in preeclampsia. So in hematological system, there will be two main changes: increased fibrin deposition, and second is the low platelet count. Fourth is the changes in the liver system. The subendothelial fibrin deposition is associated with the elevation of the liver enzyme. This can be associated with hemolysis and a low platelet count due to platelet consumption. The presence of these findings is called HELP syndrome. HELP is an abbreviation of from H hemolysis, from E elevated liver enzymes, and from LP low platelet count. So HELP syndrome is a complication of preeclampsia. HELP syndrome is associated with a range of serious complications such as acute renal failure, placental abruption, and stillbirth. Neurological system. Vasospasm and cerebral edema leads to convulsion, and this is also a complication of preeclampsia, and this condition is called eclampsia. Hypertension, proteinuria plus development of fits is called eclampsia. Now, what is the clinical presentation of preeclampsia? So, first, what are the symptoms that are present in patient with preeclampsia? Although the majority of women with preeclampsia are asymptomatic, but the classic symptoms are a frontal headache, epigastric pain due to the changes in the liver system, visual disturbances due to the cerebral and pupil edema, and generalized body swelling. What are the signs on clinical examination? In patient with the preeclampsia, a detailed obstetric and neurological examination should be done. So the patient will have high blood pressure. There will be generalized or increased pedal edema. Although the pedal edema is common in pregnancy, however, rapidly progressing edema of the face and hands may suggest eclampsia. Epigastric tenderness is a warning sign and suggests liver involvement. Due to the involvement of the liver in preeclampsia, there will be epigastric pain. Hyperreflexia due to the involvement of the neurological system. Clonus must be checked in patients having suspicion of preeclampsia, and urine protein examination should be a part of the clinic examination. So proteinuria is also a sign of preeclampsia. What investigation should be done in patients with preeclampsia? To monitor maternal complication and to assess the fetus. To monitor the maternal complication, full blood count should be done with specific emphasis on falling platelet count and rising hematocrit. If in full blood count the platelet count is normal, then there is no need to go for coagulation studies. Serum renal profile, serum liver profile, serum uric acid, and the for monitoring of the fetus, the count should be done for the fetal size and expected fetal birth weight, for the amniotic fluid volume, and maternal and fetal Doppler should be done to monitor fetal growth. Now, once we have diagnosed a patient with preeclampsia, what should be the plan of management? There are two basic components of the management. One, we have to control the blood pressure of the patient. Second, we have to prevent the development of fits so that the patient not proceed to eclampsia. That is for the mother. And for the fetus, we have to take the best possible decision for the fetus depending on the duration of gestation and the condition of the mother. The standard and recommended management of preeclampsia is delivery of the baby, because once the placenta is there is risk both to the mother and the fetus. But we have to take decision in the best possible interest of both the mother and the fetus. This table shows the nice guidelines recommendation for the management of the preeclampsia. First of all, we will divide the patient into three main groups depending on the degree of hypertension. Mild hypertension, that is 140 by 90 to 149 by 99 millimeter of mercury, that is mild hypertension. Moderate hypertension, 150 by 100 to 159 by 109 millimeter of mercury. And severe hypertension, 160 by 1 millimeter of mercury or more than this. So, once a patient is diagnosed as having preeclampsia, admission to hospital is must, both in mild, moderate, and severe hypertension. Now, what should be the treatment plan? So, if the patient is having mild hypertension, there is no need to treat. Just admit the patient for observation, and her blood pressure should be checked at least 4 times a day, and Her blood investigation should be done twice a week, including full blood count, renal function, liver functions, and serum electrolytes. In case of moderate hypertension, we have to lower the blood pressure, and for that, multiple drugs can be used, but labetalol is used as first line. In case of moderate hypertension, we have to keep the diastolic blood pressure between 80 to 100 millimeter of mercury and systolic blood pressure less than 150 millimeter of mercury. Same is the case for severe hypertension. Blood pressure should be controlled with the labetalol or labetalol, and the aim is to keep diastolic and systolic at the same range. In case of moderate hypertension, the blood pressure should be checked at least 4 times a day. However, in case of severe hypertension, it should be checked more frequently depending on the clinical circumstances. In case of moderate hypertension, the blood investigation should be repeated 3 times a week, and similarly in case of severe hypertension. So the management plan in case of moderate and severe hypertension is almost same. This is the nice recommendation for the management of preeclampsia. So first is the treatment of hypertension. The aim of antihypertensive therapy is to lower the blood pressure to reduce the risk of maternal cerebrovascular accident and not to disturb the uteroplacental blood flow. There are a variety of antihypertensives used in the management of preeclampsia. Number one is the methyl dopa. This is methyl dopa is a centrally acting antihypertensive. It is safe in pregnancy. However, its use is associated with unpleasant side effects, including sedation and depression. Second is the labetalol. Labetalol is an alpha and beta blocker and can be given both orally and intravenously. Labetalol is recommended as first-line treatment for the control of hypertension. Third is nifuripine. Nifuripine is calcium channel blocker and it is a rapidly acting antihypertensive agent and it is also safe in pregnancy. In severe cases of pulmonary disease, an intravenous infusion of hydrolysine or labetalol can be used to control the blood pressure. So these four are the main drugs that are used for the control of hypertension in pregnancy. Thus, labetalol is the first line. So one objective of management is to control the blood pressure. Second is treatment and prevention of eclampsia. The drug of choice for the prevention and treatment of eclampsia is magnesium sulfate. It is given intravenously until convulsions are stopped. The detail about the dose, the method, and the monitoring of giving magnesium sulfate will be discussed later on in treatment of eclampsia. But at this stage, you should be able to know that what is the treatment option for the prevention and control of seizure in patient with uh, preeclampsia. Delivery. As already I told you that the management of preeclampsia and eclampsia is to deliver the baby. In case of eclampsia, you have to deliver the baby irrespective of the period of gestation. But in case of preeclampsia, you have to look for both the maternal and fetal condition. because if there is mild hypertension and the mother is stable, you can wait for the maturity of the fetus. But if there is severe preeclampsia or imminent eclampsia, we have to go for delivery irrespective of the period of gestation. So, iatrogenic preterm delivery of the fetus is often required in severe preeclampsia. Steroid cover should be given prior to 34 weeks of gestation. In order to prevent the risk of neonatal respiratory distress syndrome. If the mother condition allows, patient with preeclampsia before 34 weeks of gestation should be transferred to a center with adequate facilities for the baby. Prophylactic subcutaneous heparin should be given in patients with preeclampsia because there is high risk of thromboembolism. Argometrin should be avoided in the management of third stage of labor as it significantly increases the blood pressure. Postnatal management of preeclampsia. Postnatally, blood pressure and proteinuria will resolve. So, once the patient with preeclampsia is delivered, we have to monitor her blood pressure regularly so that we, because the risk of development of preeclampsia is very high up to 7 days after delivery. So it doesn't mean that once the patient is delivered, we have to lift her as such. We have to monitor her blood pressure. If persists, the high blood pressure persists beyond 6 weeks, it suggests the presence of underlying chronic hypertension or renal disease. And the patient who presents with severe preeclampsia before 34 weeks of gestation should be screened for underlying medical disorder. Now, how can we screen and prevent the development of preeclampsia? Unfortunately, currently there is no screening test of preeclampsia. There is no single biochemical marker or symptom or sign that by which we can screen a patient for preeclampsia. As far as prevention is considered, the use of low-dose aspirin 75 milligram daily modestly reduces the risk of preeclampsia. So if a patient is having history of eclampsia in previous pregnancy, we have to start her from the start of pregnancy with low dose aspirin to reduce the risk of preeclampsia in this pregnancy. And third is the calcium supplementation may also reduce the risk of preeclampsia. Also, its role is not highly specific. So in summary, at booking, we have to look for the risk factors. If a patient is having multiple risk factors for preeclampsia, we have to be vigilant throughout pregnancy for to prevent any complication related to preeclampsia to both mother and fetus. And we have to properly, timely manage the patient.